All right, welcome everybody for Health Policy Grand Rounds this month in person. It's a busy month, so those who don't have it on your calendar, look on our website about the Health Services Research Symposium next week on Tuesday here at the Mission Bay campus. It is an all-day event. We have the incoming president of the American Medical Association as a keynote speaker, and then we have the current for about one more month president of the AMA leading a closing panel on health equity and health services research. So it's going to be, and lots of cool stuff happening all day. So it's going to be a lot of fun. Hope we see you at that. But before we get to that, we have got Brian Miller here. He is at Johns Hopkins University School of Medicine and is also a non-resident fellow at the American Enterprise Institute. And does a lot of other cool stuff because I've been stalking your bio since Anthony mentioned that we should try to invite you out here for Grand Rounds. So he has a research group that is looking at market-driven solutions to FDA regulatory policy, which is clearly lately been a hot topic about how the FDA regulates things, the Supreme Court being among those looking at that issue. But more interestingly today is this work on hospital consolidation, which I'm very excited to see. So thank you for coming in person, and I'm looking forward to having lunch later.
Thank you. Thank you all for inviting me. I live in DC, and it's nice. I grew up on the West Coast, and it's nice to finally get a decent cup of coffee after about 15 years. This is one of my favorite topics. It's a controversial topic. It's a topic that has also gotten me death threats, which is a sign that, it's something we should be exploring more. It's hospital consolidation. I started off with this picture from the Gilded Age because we had great comments and great commentary at the time about the sort of captains of industry and government capture and regulatory capture. And it's very, I think, appropriate for today. I'm going to spend some time talking about problems, then of course coming with solutions. I always, sorry, technical issue. I always do my disclosures. I'm actually paid in a very boring fashion by universities. I occasionally go talk to medical groups, which will support my travel to go out. I have grants from, as you can see, a variety of organizations, all of which disagree with each other. And I think that is important. I'm also on the Medicare Evidence Development and Coverage Advisory Committee. And then I'm an expert witness for the Federal Trade Commission on an insurance advertising case. I also serve as an advisor to members of Congress and their staff and receive no compensation for that. And of course, my views are my own and don't represent those of Johns Hopkins University, Johns Hopkins Medicine, or the American Enterprise Institute. Hospital consolidation is a really fun topic for me because I worked for basically every major federal regulator. So that's CMS in the upper left-hand corner. I worked at the CMS Innovation Center, helping stand up the ACO investment model, which focused on rural and underserved areas. I also worked at the FTC, which has been in the news a lot recently. It was a fun place, very exciting, very vibrant. And it was a diverse group of people with diverse views who all agreed that competition is important to the lifeblood of the American economy. While I was there, I worked on hospital mergers, physician practice mergers, retail drugstore mergers, pharmaceutical product mergers, medical device mergers, and then one that is important for the medical profession, which they probably have some disagreement with me on, is scope of practice and competition policy. I also worked at the FDA. That's the picture of the FDA campus, the famous sculpture garden. I was in the policy shop and then also as a reviewer in the Center for Drug Evaluation and Research, reviewing drugs for market entry and also working on post-market regulation. And then, of course, at the FCC. I have a pretty big group of good people. This is not just my thoughts, a product of everyone's thoughts. We're from all walks of life and we're multi-generational and we cross geographies. So we have a lot of fun together, causing a lot of positive mischief, hopefully promoting positive change. So today we're going to sort of talk about three areas. One is we're going to define the problem. We're going to sort of talk about tools that are available, and then of course, recent efforts. I welcome, if you have questions, you can save them till the end, or you can interrupt me. Just justify or specify that you want the question answered now. I'm okay with a conversation and, in fact, encourage it. So healthcare policy is in sort of a weird place right now. I put all these people up, and they're all very different. So, you know, in the upper left, that's Senator Lee from Utah, who is a known classic libertarian. Then you have Senator Klobuchar from Minnesota, who's on a trust-busting anti-monopoly wave. Also, you have the Department of Justice anti-trust division head, the FTC chair, Lena Khan, and then that's Kevin Hern, who's the chair of the Republican Study Committee in the House. And they're all in agreement, actually, that hospital monopoly is a problem, and consolidation in healthcare markets is a problem. And usually you don't actually get that agree, you know, that's a pretty wide range from the progressive antitrust chair of the Federal Trade Commission to the Republican Study Committee chair in agreement about the confines of an issue. And so everyone's upset about this. And it gets to the existential question of how do you solve a problem like monopoly? And it's easy for us to talk about, and we should have some fun talking about it, of course, but it's actually not as easy as we'd like to think. And, you know, it's really just not hospitals anymore. So you can pull these great stats, like the Healthcare Cost Institute has shown that, you know, MSAs 90% are concentrated for hospitals. So it's not concentrated by an arbitrary definition. It's the generally accepted HHI cutoff of 2,500, which the Department of Justice Antitrust Division and the FTC both agree on, and most experts agree. There have been lots of hospital mergers. I found a nice longitudinal stat that's I think we can agree, a pretty big number. That's a four. It's not just hospitals, right? Like everyone's getting bought up. You know, the joke is while becoming in health affairs that talked about the changes in primary care physician employment and also specialists. So like we're all becoming employees of these large health systems. And then the question is, of course, why are we interested in this? And the answer is that consolidation hurts workers, right? We all have a job and have to pay the mortgage. In antitrust, labor competition is sort of the new policy angle. And the trades face health systems with monopsony power, right? So whether you're a nurse, a physician assistant, a physician, or the janitor or the scrub tech in the operating room, right? Like you do not have a lot of choice about where you work, right? If your choice is one employer or two employers, you don't have any bargaining power financially for what your job structure looks like, your benefits. And I would say on a bipartisan fashion, both parties are very concerned about the healthcare workforce, right? There's this epidemic of physician burnout, an epidemic of nursing burnout, nursing turnover in some hospital floors. A variety of hospitals can exceed 100%, right, on a year-to-year basis. And, you know, there's a variety of actions, right? There's unionization of residents at hospitals. There's the FTC proposing a ban on non-competes for economy-wide, which would, of course, have significant effects in healthcare. So there's a lot of interesting action in this space. And then, of course, there's the academic answer, which is what I call economic, patient, and physician harms. The joke is in policy is you can pick your favorite economist, you can pick your favorite statistician or health services researcher. Well, you actually can't do that here because they all agree. So you can't go cherry pick an expert, right? Like, for example, there's the 2020 New England Journal study by Lee Moore Daphne and colleagues, which looked at hospital mergers. They found no quality gains from hospital mergers. Quality gains, and they looked at real things, right? Like 30-day readmissions, 30-day mortality. It's sort of hard to fake a 30-day mortality gain or loss, and they didn't find one. They did find a worsening patient experience, which, you know, anecdotally, we can all imagine trying to navigate a large health system as a patient. There were great work by the Kaiser Family Foundation, RWJF, going back over a decade, showing that horizontal consolidation raises prices. For example, hospitals that are solo hospitals within a 15-mile radius have a 12% higher price than markets with 4 or more competitors. You know, 12% is not just statistically significant, that's a real price difference. And then, of course, the National Academy of Medicine looked at clinician burnout. And they found that one of the key drivers of clinician burnout was what they call loss of control over the clinical practice environment. And so what has happened is when you join a large health system, you no longer determine the parameters of your clinical practice and you don't have any input. So why should policymakers or why should Congress care? Well, if you have a monopoly or you only have one or two competitors and you get sick, you don't really have a choice. So you're stuck. There's one rheumatology practice you can go to, one hospital, tertiary care hospital. And then for the clinicians, right, we're all different. We have different styles of practice. I'm an academic. I love practicing in an academic medical center. It's fun for me. I enjoy it. Not everybody enjoys that. I don't want to dictate that everybody else should practice in an academic setting, or the VA is a great environment. I trained in VAs, have fond memories of the DC VA, and I do miss it. For all its benefits and warts, it was a good place. Private practice, whether you're in an integrated delivery system, having clinicians have that choice over how they practice is important. And then, of course, cost. People can't afford medical care. It's expensive. Monopoly drives up prices. Health insurance premiums go up, right? Health insurers, to some degree, are a bank, right? They're just aggregating the services and products and then passing that on to a consumer as an aggregated product. And we can increase the insurance subsidy, right? But that, of course, just masks the underlying problem. The problem I personally am most concerned about is that last one. You don't have competition, you don't change how things are done, right? There's no innovation in service delivery. And the sort of scary answer about that is we all get sick eventually and have to go to the doctor. And then we're stuck navigating that large, massive corporate health system that is not focused on the patient experience. And economically, if you go to the Bureau of Labor Statistics, there's this wonderful graph, and I pointed this out in my Senate Judiciary testimony about 2 years ago, and then eventually it disappeared from the internet for a little while and came back when I asked about it. But if you look at this, labor productivity has been flat, and you look at the last 10, 15 years, it's really flat, and then you go back to the mid-90s and it's about the same. And so this is pretty abysmal, right? Like, I think we can all agree that most economic sectors are not like this. I would say that this is an example of regulatory protections, consolidation, or even just outright monopoly, and of course, massive subsidy. And so you're like, great, Brian, like you just made us all depressed. Like, what can we do about this? And the answer is we actually have lots of policy tools. And I think the important thing is that to look at sort of history, recent history, some of them in the past, about things that haven't worked as well. It doesn't mean that we won't try them again. We have used direct rate regulation in the past. Many states had rate regulatory consolidation and rising healthcare prices. A more recent trend is the expansion of certificate of need regulation into certificate of public advantage to give hospitals an exception to mergers if they're supposedly benefiting the public good. And that has, of course, resulted in driving consolidation. And then, of course, state global budgets. The states that had those, there one state that still does, still have reasonably consolidated markets. And so then the question is, and apologies for all the text, is what's driving all this consolidation, right? So like people respond to incentives, good or bad. And the answer, I'd say, is these three buckets, right? First is what I call payment policy arbitrage. The other is sort of anti-competitive corporate behavior. And then, of course, a lack of market entry. The payment policy arbitrage one is sort of fun, right? It's the buy and bill more. It's bill more, not build more. It's like the used car salesman, right? Like you can buy clinics, they qualify for 340B, you can buy drugs at a lower price and then sell them in the employer-sponsored market at a higher price. Of course, that's an incentive to go out and buy things. You can also buy and bill higher. This is where, and Congress has partially corrected this. You can go out and buy clinics, designate them, and historically you could designate them as a hospital outpatient department, not actually change clinical operations or infrastructure at all, and just bill more. And so that's a great incentive to go buy things. And then there are other things that we have, like the inpatient only list, which is a list of procedures that you can only do in an inpatient setting. The classic example would be, 20 years ago, total knees and total hips were done only in an inpatient setting, and now most of them are outpatient. And then, of course, there's the sort of anti-competitive behavior that corporations have engaged in. The enforcement jurisdiction games, as I call it, and I include the two examples there, right? So tax-exempt hospitals, if they merge, they go to the FTC, which has mergers for, and the Bureau of Competition, which are, a group of lawyers who are very experts at looking at hospital mergers and do. It's one of their core businesses. But if you're a tax-exempt hospital and you're engaged in anti-competitive conduct, the FTC doesn't have jurisdiction, and so it gets shunted down the street to the Department of Justice Antitrust Division. Sharp crowd, but wouldn't it make more sense for the people who deal with hospital competition every day to have that opportunity to address that? There's anti-competitive contracting, where hospitals put anti-steering, anti-tiering provisions, so health systems can't direct patients to other hospitals. And then, of course, hospitals and health systems want to avoid what they describe as leakage, and they actually describe it as that in documents. And they want to capture the entire healthcare dollar, and they go buy everything possible to do that. And I realize that these are sort of like after the fact concerns, but there are things that we could fix. And if we do fix, health systems will change their corporate strategy. And then that last one, market entry is super hard. Easy to say, hard for me to do. And so the question is what are people doing about this right now? And the answer is there's actually a lot. You could give the FTC that authority. And, I said that they don't have the authority for anti-competitive conduct. Congress could give them that authority specifically for healthcare. I'd say probably due to partisan squabbles, that's probably dead on arrival right now, but it's something that will eventually be picked up later. You could address anti-competitive contract terms. I think both policymakers in both parties are very concerned about that, and that's something that could be addressed. You could have a state competition index, measuring market concentration, which would be like a map for state attorney generals to engage in antitrust enforcement. And then, of course, you could eliminate payment policy arbitrage, get rid of the inpatient only list. There is some movement for that. Site neutral payment, which is a fun one I'll get into. There's a lot of political steam behind that. And then, of course, reforming 340B. If we think that the 340B program is a benefit for the patients who can't afford drugs and can't afford healthcare, should that benefit follow the patient instead of the health system, and follow that patient wherever they go, be it a tax-exempt hospital, for-profit hospital, and FQHC. And that's something actually that one of our colleagues here, Anthony DiGiorgio, has been working on. So mergers. I mentioned mergers. I got to work on hospital mergers. This is the North Shore University Health System Advocate Health merger, and Advocate has since merged with a variety of other organizations. Why do I mention this? Shows the timeline. So if you look, in December 2015, a complaint was filed. There was a legal challenge. There was a trial. That's Alexis Gilman, who is the head of mergers for at the time. And then, of course, there was a finding in favor of the FTC. And the best part is when you win the case, you get to design the merger trophy. So I designed the merger trophy. It's the ambulance and it has the logo on every side. So merger challenges are great. The FTC needs more staff and funding to do that. But there are lots of mergers a year, and you can only challenge so many. So for example, in 2019, there were 67 hospital and ambulatory care mergers with only a handful that were challenged. It takes a lot of human capital to do that. And as you can see, it takes a lot of time. But that is one of the levers that we have. Another lever is site neutral payment. This is a fun one. I picked these three examples. So I wrote an op-ed about site neutral payment. The Blue Cross Blue Shield Association, representing untold millions of members, is in favor of site neutral payment. And then the Committee for a Responsible Federal Budget, which is a nonpartisan center or center left think tank, is also in favor of site neutral payment. So there's a lot of political energy, I would say, behind that. And it just makes common sense, right? Like you shouldn't pay differently for the service based upon where it's delivered. You should pay for the service, and then people should deliver it in the place where it's clinically appropriate and economically efficient. The inpatient only list is another sort of example in this space. And then, of course, there's the answer of, okay, great. So you're eliminating some payment policy arbitrage and you're increasing competition, but that's probably not enough, right? Like that's what the policy experts in DC say. They're like, okay, Brian, like you got us partway there. You didn't get us completely there. What are you going to do? And then, we get to this sort of hard question, right? Market entry, like if you have a consolidated market and there are only a couple of hospitals and they're all owned by one, massive corporation, yes, you can break up the corporation. Yes, you can eliminate the incentives for the corporation to go and buy all these other parts of the healthcare supply chain to encourage competition, but that takes time, right? So how can you get people to build a hospital? And then they say to me, Brian, building hospitals is really hard and really expensive. And they'll tell me things like a micro hospital is $25 to $50 million. And I'll say, well, what about tertiary care centers? And then they'll give me some stats and they'll be like, it's $1.5 million per bed, right? That's sort of a lot of money, right? And then you think of some examples and you're like, oh, is that a real number? And like I looked up Russia's 304 bed pavilion that they built. That was $654 million. And Georgetown built a surgical pavilion, which was $567 million. So that's a lot of money. And then they, you feel a little sorry for the hospital executives there because raising that capital is not easy. And then they're like, well, regulatory barriers are hard, right? And you're like, what are the regulatory barriers? And at the local level, there's zoning, there's permitting, there's a traffic study, there's usually environmental impact, and all those things make sense, but that makes it hard to then build a hospital. And then at the state level, there's facility licensing, certificate of need, often certificate of public advantage. And then at the federal level, there are Medicare conditions of participation. And then suddenly, this looks a lot more challenging. And the question might be then, who is silly enough to want to go build a hospital, right? Like who would want to, go raise all of that capital, do all of that regulatory requirements and study and development planning? And the answer is, well, my personal profession is silly enough to want to go do that frequently, go out and build hospitals. And physician-owned hospitals are something that is actually common in other markets. If you look at Canada, right, which has the regional publicly funded payers, the Shoulder Hernia Hospital, where Senator Rand Paul had his hernia repaired after he had that chronic cough after that altercation with his neighbor. That is a focused factory that is a physician-run enterprise. And then Narayana Health, which was in India, which is primarily a private payer market, was founded by Dr. Shetty, who's a cardiac surgeon, to create a focused factory for the poor for cardiac care. So it's a market that's been sort of around for a while in other countries. In the US, it's a little over 250 hospitals, and half of them are community hospitals offering everything from labor and delivery services to emergency rooms to primary care. And then the other half are focused factory specialty hospitals. And so the great thing I think about competition policy, and this shows Pete Stark with his colleague across the aisle, is that it sort of forces us to rethink old ideas and re-examine questions in a new context. And the question with physician ownership is of course, self-referral, right? Like you're a self-interested party. If you own the MRI machine or the CT scanner or whatever, you can suddenly refer all of your patients to that and, of course, bill. And there's the asymmetry, right? So that's induced demand. And then there's the asymmetry of information, right? As a professional, as part of the trade, you know more about the services that you're offering than the consumer in front of you. And then, of course, this drives cost. And, I remember my old professor told me about the healthcare cost equation. It was an endless lecture in an evening class, and it was great. And it's still valid, 15 plus years later. And it's that the total cost of care is a function of the price of the service, the volume of the service, and the intensity of service. And most of us, know what the intensity of service is. But for those who don't, if you're a 35-year-old patient and you don't have any health problems, you can go to the doctor, and the doctor, you describe your symptoms, and the doctor thinks it's reflux, and they say, take a proton pump inhibitor and come back and see me in 6 weeks. Right? That's low intensity care. If they show up and they say, I'm really worried about you, your second cousin twice removed had a heart attack at the age of 55, I'm going to order an EKG, a treadmill stress test, and an echocardiogram. That's high intensity care. And so the total cost of healthcare is modulated by all three of those. And the concerns about self-referral were highly justified. There was a lot of research that came out in the 80s and the 90s about physician self-referral driving induced demand in a fee-for-service setting, right? And I picked some of the great, well-done papers. There was also this CMS paper in 1998 about the volume, and it was even a team. It was called the Volume and Intensity Response Team. And they published a paper that showed that physicians responded to market incentives in a fee-for-service setting, which was not surprising. And then this resulted in Stark Law, championed, of course, by Congressman Pete Stark. It was passed as a series of reforms and then also rulemaking in the 80s and 90s. And there was something called the whole hospital exception, which allowed physicians to continue to refer patients to a hospital that they owned an interest in, which was closed as part of the ACA. And then a couple of years ago, there was some initial reforms about value-based care. And then the question is, of course, well, we talked about physician referral for services. Where did this referral concern about physician-owned hospitals come? And well, interestingly enough, industry is pretty sophisticated and they're very good at getting, through lobbying, certain things stuck into legislation, including mandated research reports about their competitors, asking specific questions in a way that, of course, pushes their competitors under the bus. And so there were a whole series of reports actually that came out from the GAO, MedPAC, and also CMS studying physician-owned hospitals. And then these were used as a rationale to promote a ban on them participating in Medicare. And so what this did, and we'll go through what their concerns were, which, as I said, were justified and addressed. They created market foreclosure by solving what was functionally a regulatory problem with a prohibition on an ownership model. And this was over a decade ago. And the economic effects at the time, right, I found some numbers were pretty big, right? So you're shutting down a couple $2 billion in investment and a significant number of hospital projects. So it's a significant economic impact. There's a loss of agency because the physician becomes the corporate employee rather than the owner-operator in an employee stock ownership plan model, which economic evidence from other markets shows us is actually a more effective business. And then, of course, there's the loss in innovation. So challenges, as I said, corporatization of the practice of medicine for those who have studied the history or experienced it was a problem in the 80s. It's a problem now. And then physician ownership arose as a response. And then there were concerns about self-referral in a fee-for-service setting, resulting in Stark Law. The Medicare Modernization Act of 2003 included an 18-month moratorium on physician-owned specialty hospitals, and then was followed by a series of reports, which then resulted in their prohibition of billing for Medicare as part of the Affordable Care Act. So why was industry concerned about this? And you sort of feel like Michael Scott did in The Office when you hear these concerns. So one of the concerns, of course, was that specialty physician-owned hospitals cherry pick healthy patients. And you're sort of, squint your eyes and wonder about this. And you're like, well, doesn't this really seem like a payment issue, right? Because if you're picking healthier patients, you should just pay people less, right? Like pay them a lot less, right? Adjust appropriately for acuity. And CMS recognized this concern and said to the hospital industry, yes, we understand. And they added a acuity adjuster as part of a case mix index, and then also complicating conditions to the DRG payment for hospitals. And I would say if there's still a problem with patient acuity or concerns about it, again, titrate the payment level appropriately. Then there was a concern of that physician-owned hospitals were not paying charity care or not providing charity care, which was pretty funny, actually, because the total community benefit for physician-owned hospitals was much higher. An example from that study, and there have been other studies since then about the tax-exempt hospitals, but tax-exempt community hospitals paid as a percentage of operating revenue at the time that study was done, 0.87% in community benefits. So not even 1%. They didn't pass the 1% mark. They were less than 1% And then, for example, physician-owned cardiac hospitals had 3.75% of revenue paid in terms of community benefit, and then orthopedic hospitals were much higher at 7.23%. The answer is why they pay taxes, right? Like you're paying federal taxes, state taxes, local taxes, property tax, or those are income taxes, also property taxes. So that's a lot of community value that they are providing to support the local economy. And then there was a concern that physician-owned hospitals didn't provide emergency services. And if you go back and look at the GAO study at the time, most of the community physician-owned hospitals did, and then some of the specialty hospitals did not. And you say, well, Brian, that seems discriminatory or inappropriate. And the answer is, if you look at the specialty hospitals, most of the cardiac specialty hospitals owned by physicians did have an emergency room, which makes sense, right? Like if you're doing a CABG, or you're doing a AAA repair or an aortic valve replacement, like those patients often present with acute symptoms. They end up in the emergency room, they get hospitalized, and then they have a repair. Or they get triaged in the ER, admitted, and then discharged and follow up in the clinic, and then later get surgery. The hospitals that traditionally did not have emergency rooms were the orthopedic-focused factory hospitals, which were structurally like an ambulatory surgery center, plus a couple beds in order to have overnight stays for the patients that needed it. Then there were, of course, concerns that public payers, patients didn't have access, and that physicians were smart and they would do the wallet biopsy and they would go only for patients who had employer-sponsored insurance or commercial insurance, and that they would enjoy those rates that were 250 to 350% of Medicare, and that's how they maintained as a going business. They didn't want Medicare or Medicaid patients. So it's actually interesting, the industry, through their lobbying and banning of physician-owned hospitals participating in the public payer programs, they did that randomized controlled trial for us, right? And so 9 hospitals in Texas opened after the Affordable Care Act ban, and they all went bankrupt within 5 years. And the answer is that you cannot exist as a going concern as a hospital unless you take Medicare and Medicaid patients. And you could say, and you could imagine a potential policy solution to that, you could put a minimum requirement. You could say that if you open a physician-owned hospital, that you must take, say, 10 or 15% Medicaid. And so you could address that policy concern with a specific intervention as opposed to banning the business model. And then, of course, the industry was concerned about quality. And so I started to look through the comparative quality and comparative cost. And so I started to read the studies, and I found a variety of different answers. And so what do you do when you find different answers in the literature? You punish yourself with a systematic review. After doing a systematic review, you always find out that you don't want to do another because they're so painful. And that's what my team found out. We sort of parsed through 30 years of research. It was a lot of fun. And even if you had a low quality study and it was relevant, obviously in a systematic review it gets included, although described as low quality. What was also interesting in looking through the literature is that some of there was a lot of economic modeling data that was done when actual data were available, which is of course always concerning, right? Like, why are you constructing a model when you have actual data you can look at? Some of them looked at measures of competition as opposed to actual comparative cost and quality. So one of the studies that my team found was that showed that community hospitals hired more nurses in response to market entry from a physician-owned hospital. I think we could all agree that that's probably a good competitive effect. So as you can, and I'll show you our flow chart, but we found that community hospitals owned by physicians, which is half of the physician-owned hospital market, have equivalent cost and equivalent quality. So their costs were similar. Their patients were slightly younger, more likely to be male, and more likely to have Medicaid, which was a sort of interesting finding. We found varied utilization for imaging. We found similar length of stay, similar in-hospital mortality and readmission rates. Cardiac hospitals, the MedPAC studies were the primary ones that examined costs. They only had a year of claims data, and the difference was not statistically significant. They had what I would call more than robust quality data and things, again, that you can't fake, right? Like AAA repair, CABG, and carotid endarterectomy. Like, these are not low morbidity, low mortality procedures. They found that the physician-owned cardiac hospitals had lower mortality and fewer complications. The orthopedic hospitals for like total knees and total hips had lower costs with Medicare and also private payers. Makes sense. Again, if you have a focused factory that is designed and set up just to do a specific number of procedures, you have lower complications and lower cost. So, and then our wonderful flow chart for doing a systematic review, we had a very broad search. We found lots of articles, excluded them appropriately by our protocol, and ended up with a final universe of 21 articles. I would say one of the most fun things I found about this was there were a series of studies that looked at specialty hospitals regardless of ownership. So they included corporate-owned, nonprofit-owned, and physician-owned, and then made a conclusion about specialty hospitals writ large, and then applied that only to physician-owned ones. So there was a lot of conflating of service markets and ownership markets, which we cleaned up. And so as I mentioned, key findings, cardiac hospitals had lower mortality and lower complication for some pretty morbid procedures. Heart failure exacerbation and MI had lower 30-day mortality. Ortho had lower cost, increased patient satisfaction, increased clinician communication, and then there are studies on cost from MedPAC, for example, were not parsed by DRG, for example. So that would not pass peer review if you submitted that today. Market segmentation, just so you can see, half the market is surgical specialty hospitals. The other half is community hospitals, or what the antitrust community calls general acute care hospitals. We looked at cost in terms of quality. We had sort of 4 buckets: general facility characteristics, pre-procedure attributes, sort of care episode measures, and then, of course, the one that we care most about, which is outcomes and complications. The question, of course, when you have policy information or information that's relevant to policymakers, what do? The answer is you publicize. So my team and I, with a variety of stakeholders, did a series of articles. The first was a JAMA Forum article a couple of years ago, sort of testing the idea of physician-owned hospitals and seeing how the policy community responded. I didn't get any hate mail, and no one threatened to bomb my house, so I continued going. I then talked to the medical specialty trades, and we wrote this article about reversing hospital consolidation in conjunction with folks who were involved in AOS, ACC, and the AMA. We then did a systematic review because in talking with the policy community, there were those questions of comparative cost and comparative quality. Then I did a competition policy paper, which I will get into in a second. And of course, then op-ed with Senator Langford on physician-owned hospitals. And I think the important policy lesson here is that you can find interesting partners. So I had a recent working paper that I wrote with DOJ and FTC staff and the AMA president-elect, who will be coming to visit you all next week, looking at physician-owned hospitals and the restrictions that they currently face. We looked at the unique features of physician ownership for innovation and service delivery. We looked at labor market effects, as I said, which is a new area in antitrust. And of course, we found that the benefits to the market are magnified from entry due to the market power of existing hospital systems. And that, of course, one of the key features that you think about in competition policy is there a less restrictive alternative? Like, is there a way that we can address whatever the policy concerns are in a way that still permits competition? Because competition is not usually replaced completely by regulation or a ban on ownership. If you go around in the antitrust community, people of all stripes agree generally that competition has benefits that you can't always measure. And so the other thing with policy issues, and this is the CEO of the Federation of American Hospitals, is you also have to sort of recognize existing problems, right? The inside baseball, the industry lobbying for self-protections from competition, which unfortunately is a very common occurrence across all healthcare industries. I would say that the hospital industry probably exceeds others in this, and Chip Kahn did a nice long interview with the advisory board. You can Google it and find it, and he talks about writing the talking points for Senate staffers about this issue, admits that, and then openly brags and said, if we hadn't been there, history might have been different. And so the question is what do you do when you encounter this sort of inside baseball? Is you engage potential allies. And I included some of them up there. Obviously the medical specialty societies have an inherent interest in making sure that physicians can own and operate hospitals. The insurance industry benefits from hospital competition. So this is a little bit like rearranging the deck chairs on the Titanic, I realize. The organized labor also has a benefit, right? Because having an physician ownership is actually an employee stock ownership plan, right? Wouldn't it be great if the workers at hospitals could actually own the hospital as opposed to only investors owning the hospital, or in the case of a tax exempt hospital, the executives being in control with a 20+ member board, in theory owned for the public good, but often not executed for the public good. And then the other important thing I would say with policy issues is that getting others to join in. So this is a sort of selection of articles about hospital consolidation and competition from a variety of venues and a variety of different stakeholders. And the great thing is that you can start a snowball effect. Then the question for hospitals, right? Because if you remember, going back, it's not just hospitals anymore, Toto, it's everybody, right? What do you do about consolidation? In the ambulatory care space, dermatology practices are getting rolled up, orthopedic surgery practices are getting rolled up. There's a lot of private equity investment in healthcare, and that's a huge concern, right? Because they engage, not always, but sometimes they improve clinical operations. Other times they roll up physician practices and just use that to increase market power with insurers and extract monopoly rents. And so the answer is that physician ownership could serve as a counterpart to a roll-up and market consolidation in sort of the outpatient ambulatory care space. And you say, well, Brian, those studies about physician self-referral in a fee-for-service setting show that physicians engage in induced demand and refer services and drive up total cost of care. And the answer is yes. And in a fee-for-service environment, those regulations probably should still remain in place. But the world today in 2023 is very different than, the 1980s and early 90s when those studies were done. So, just the other week, the Medicare Advantage market penetration surpassed 50%. It's now 50.2%, and Medicaid MCOs are 72% of the public payer marketplace for Medicaid. And you're saying, well, Brian, why does managed care matter? And the answer is plans are paid on risk-adjusted capitation, right? And you can, of course, and we should have those debates about those capitation rates and about risk adjustment and make sure it is done appropriately, ethically, and in a transparent fashion. But that is functionally a population-based payment. In a setting with population-based payment, you have a natural incentive to police induced demand through things like utilization review and prior authorization, which as a physician and as a patient, I've experienced both of them. They can both be unpleasant, but they also serve an appropriate function. And so that could actually serve to combat a lot of the poor incentives that could happen from physician ownership. And so I think it's worthwhile for policymakers to also consider waiving Stark under managed care setting with risk-adjusted capitation and utilization review as potential tools. With that, we still have a lot of work to do, obviously, in improving hospital competition, but I wanted to open it up to questions. Thank you.
Sorry, so I wasn't aware of this ban on that ownership model. Could you go into that a little more? And what happened to existing physician-owned hospitals after that ban went into effect?
So the existing physician-owned hospitals, that's a good question. I believe was after March 31st of 2010, you couldn't expand. So you can still exist as a business, but you're frozen in time for the past decade. There are 2 or 3 exceptions. If you have a high Medicaid area, you can apply for an exception as an example, but then that goes through a notice and comment, which of course, as you can imagine, the hospital industry usually protests. And the criteria are, shall we say, not necessarily always objectively applied. So functionally, they cannot expand. So there are round numbers, 250, 270 physician-owned hospitals, half community hospitals, half specialty hospitals, which exist in the marketplace, but they can't grow.
Oh, sorry, I had a follow-up question.
Of course.
Sorry, when you did your review,
Yeah.
did you look at I guess burnout would be the word. Because if you go from a model where a few investors are getting rich
Yeah.
to one where maybe you only have a few physicians get rich, but the other physicians who work there are still feeling burnt out. I mean, I don't know how the model works and how it affects.
There wasn't necessarily data on burnout that was available to review. Your question though is valid. Like, is it just two cardiac surgeons who own the hospital, or do a variety? And the answer is, so first of all, half of physician-owned hospitals are usually joint ventures with an existing health system. So it's a way to align incentives and improve clinical operations. And then in that case, it's usually a large number of investors. For other physician-owned hospitals, it's usually the physicians who work there who are investors and owners. So it's usually not just one or two, which makes sense, right? Like if a micro hospital is $50 million to build, and a tertiary care center hospital is, $1.5 to $2 million per bed, and 200 to 300 beds, right, or more, 400 or 500. Usually, you have more than just a handful of physicians. So, like one of the examples is Doctors Hospital Renaissance, which is in the Rio Grande Valley at the border of Texas. And the evolution of these facilities is telling. It originally started as like a procedure suite that then grew into an ASC, that then grew into a hospital, and then grew into a large tertiary care hospital. Now they have opened residencies in like OBGYN and family medicine. They do kidney transplants. And that's because they're serving a border population that the other hospitals, frankly, aren't interested in serving. So a lot of these facilities also grow organically as clinicians realize that there is a need.
I have a 2-word question.
Hmm?
Kaiser, Geisinger. What do you, well, first, I mean, for people here, I think that question about referral and self-referral and ownership for people who don't understand Kaiser are probably like, how the heck does Kaiser exist? And don't they do a good job? Which are 2 separate questions. And then the other is this Kaiser Geisinger is fascinating.
So,
any thoughts?
So that's a good question. So Kaiser is a different model. Kaiser is actually 3 corporations that work together in synergy. So the medical group is a for-profit medical practice corporation owned by the physicians. The hospital corporation and the health plan are both 501c3 tax-exempt organizations that have a board interlock. So functionally, they have the same corporate board. The medical group has an exclusive contract with the hospital and with the health plan. The hospital has a contract with the health plan, which is non-exclusive, right? Because they also had to participate in other health plans. So it creates this sort of business group and internal marketplace. I think that there are, Kaiser as an integrated delivery system can and does frequently provide higher quality. Not always, but frequently. There are, of course, tax questions about Kaiser based upon that unique corporate structure with 2 tax-exempt organizations and a for-profit organization. I would think that Kaiser would be in favor of physician ownership, right, as a way to expand their business model. Historically, though, the hospital corporation and the medical group have fought for dominance in that sort of triumvirate with the health plan left on the side. So I think in terms of how they would view this model, depending upon who you ask, you might get a different answer. Geisinger, that acquisition is happening through Risant Health. That obviously has to go through clearance from the state attorney generals. It also has to go through FTC clearance or potentially DOJ clearance, depending upon whether it's primarily reviewed as a hospital transaction or an insurance transaction. So there's some sort of agency arbitrage that's happening there. Risant Health is owned by the hospital corporation. So at least from a corporate strategy perspective, it looks like it is the hospital trying to grow its hospital, payer group without the medical group. So Kaiser actually had, and some of you may be familiar with this history, in the 90s under David Lawrence, who is actually an alum of the public health residency that I graduated from at Hopkins, tried to undergo a national expansion with M&A in the Carolinas, also in other parts of the Southeast and the Midwest. And the merger integration did not go well, and they eventually shed most of those subsidiaries because the Kaiser model was a model that was grown organically, and it was hard to integrate new businesses into that. So I think one of the other questions on Risant Health is, how is 2023 different from the late 1990s in terms of buying other health systems and then integrating them? Because Kaiser has a very unique practice structure and a very unique way of doing business. And of course, will the medical group get upset and revolt against the parent company or the partner companies as a result?
It's going to be fun. The group health acquisition worked, I would hypothesize, because the group health of Puget Sound model was very similar to the Kaiser models. That was an easy.
It was. And actually, my first paid job ever was a summer intern in their corporate headquarters. So I can say it was very for the physician practice group. It was actually very similar to the Kaiser model. They sold the hospitals in the mid to late 2010s. So Kaiser was functionally buying the medical group and the health plan, which operated under almost the exact same model that Kaiser Northern and Southern California did. Good question. Other questions? So everyone's going to go on a anti-hospital monopoly campaign.
What do you think about the effectiveness of Massachusetts' efforts with their cost benchmarking?
So, I think cost benchmarking is a good start, but I don't think it's necessarily going to be effective in the long term. And it's not objections to one policy or another. The issue is that the Massachusetts market is highly consolidated. Partners Healthcare, now Mass General Brigham, controls such a large portion of the Metro Boston area marketplace that I think that, the state attorney general and the FTC would have to take a close look at potential anti-competitive behavior that organization has engaged in. It's in many ways similar to the UPMC Highmark duopoly problem in the state of Pennsylvania. And so the sort of benchmarking and rate regulation, again, those are after sort of effects. They don't address the core problem. It's like sticking a Band-Aid on it without actually addressing the monopoly issue. And so I think that from a policy and also a political perspective, we have to ask that uncomfortable question about what are we going to do about some of these massive existing hospital monopolies. And we actually have to tackle that, as opposed to just saying, well, this is really hard, so I'm just going to go with this alternative approach and call it a day. Like, if we don't ask these tough questions, like, care is not going to get cheaper. It's also not going to get better, because one of the things that happens when you don't have competition in care delivery is service doesn't get any better. I remember this large health system that shall remain nameless that tried to hire me once. And I went, this was many years ago, and I went to visit their hospital. It was a beautiful hospital, lots of marble and art, and they had a lot of infrastructure. And it was very hard to navigate, right? And I was being led around there by an executive, and they had the long lines for the check-in, and then you went to your specialty clinic and you checked in there and you waited, and then you waited when you went to the back room, and it was this gargantuan multi-100,000 square foot campus, right? Like, you could take a golf cart around it. It was quite large, and they had gas-powered golf carts because the electric-powered golf carts wouldn't last long enough on the charge. And I remember asking and saying, well, if you're elderly and sick, like, how do you navigate this facility? And they said, don't worry. And I said, really? And they said, yes, we have an iPad app that gives you turn-by-turn directions. And the challenge there is, yes, you solved the solution, but the answer is that this is still not really consumer accessible. And so when you have these large monolithic health systems that are not subject to competition, they aren't accountable for the consumer experience, and thinking about ways to innovate that in a nimble and flexible fashion that actually works for the end consumer, which is the patient. And I said that the scary part about this is that we're all going to get sick someday, and we're all going to be subject to that. Whether we're older or younger, whatever happens, we will someday be subject to that system. And so I would rather be subject to a system that is easier to navigate, rather than one that even I, as a physician in a position of relative privilege, I have a very hard time navigating as a patient. Well, thank you for the opportunity to join and talk about this very fun and controversial topic. Hope that I have an opportunity to work with some of you on these policy solutions and on other research. And you have a great group, and I enjoyed having the invitation to speak here. Thank you.